Thank you all so much for joining us. Our webinar is going to be beginning shortly. Before we get started, I'd love to tell you about some upcoming events that we have going on at the center. On Wednesday, April 21st, we've partnered with the Northwest Center for Occupational and Environmental Health and Safety and Dr. Stephen Bao, PhD, CPE, to offer a free webinar on the Washington State Janitor's Workload Study. On Wednesday, May 5th, we've partnered with Dr. Tiana Rogers for a free webinar on racial disparities in COVID-19 mortality among essential workers in the United States. And our next industrial hygiene themed webinar will be on Tuesday, May 11th, in partnership with the University of Cincinnati Education and Research Center and Sergey Grispin, PhD, on respiratory protection in the COVID-19 pandemic, research findings from the Center for Health-Related Aerosol Studies. We also have an online course, Human-Centered Design, being taught by Dr. Jim Potvin, beginning on May 10th and running through July 2nd, 2021, which will focus on the role of human factors and ergonomics in the design of occupational tasks and consumer products design. For more about these webinars and other upcoming events, you can visit coeh at berkeley.edu/about-CE. And on behalf of education and research centers throughout the country, we're pleased to present the Industrial Hygiene Webinar Series. This offers free webinars the second Tuesday of each month. This collaborative effort is on behalf of each ERC's continuing education program and aspires to provide access to all of the current research being supported through NIOSH ERC programs. Thanks so much for being with us today. Today's webinar, Estimating Indoor Transmission Risks of SARS-CoV-2, is brought to you by the New York, New Jersey Education and Research Center and Brian Pavlonis, PhD, CIH. A few housekeeping items first. You'll be muted during this presentation. If you'd like to ask a question, please enter it into the online Q&A box. We'll be saving time at the end of the presentation to address as many questions as possible. This presentation is being recorded and will be made available on the COEH YouTube page. All participants who logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to the recording and an evaluation form that will qualify participants for a certificate of completion with one continuing education contact hour. Once the evaluation is completed, you'll be able to access and print your certificate. Without further ado, it's my pleasure to welcome our presenter for today. Dr. Brian Pavlonis is a certified industrial hygienist who has been working in occupational health and exposure science since 2012. He joined the CUNY SPH faculty, or CUNY SPH faculty, in 2014 as an associate professor. Prior to joining SPH there, he was a postdoctoral fellow at Rutgers University in the Exposure Science Division after earning his PhD at the University of Iowa Industrial Hygiene in 2012. At CUNY SPH, he has developed and taught courses in industrial hygiene, noise radiation, and industrial ventilation. In 2016, he was named Industrial Hygiene Program Director for the New York, New Jersey NIOSH Education and Research Center. His research aims to understand human exposure in the occupational environment and to characterize risk due to exposure. Thank you so much for your presentation today. We're looking forward to it.
Thank you. Thank you for having me. So the objectives of this lecture are, first, we're going to go through the mechanisms of SARS-CoV-2 transmission. Second, to identify the data necessary to conduct a quantitative infectious risk assessment using the Wells-Riley model. And then finally, I'm going to walk you through two studies that we recently published. One, applying the Wells-Riley model for estimating risk in New York City schools, and the second for estimating risk in New York City nail salons. So in the presentation, I have the citations for both those studies. So we have a limited amount of time. So if there's any questions about the methods in there, those both have been published. So you can just go back to them if I possibly leave anything out or anything's not clear. So the CDC defines 3 routes of disease transmission. We have airborne or aerosol transmission, and this is what we're going to focus on most today. We have large droplet transmission, and then finally contact from contaminated objects. Now, airborne transmission involves infectious microbes that are very small in diameter and remain infectious over a long period of time. Just due to their small size, they can travel very large distances compared to your large droplets, which quickly settle out of the air. Finally, as we learn more about SARS-CoV-2 and COVID-19 disease, we're becoming more aware that contaminated objects, really aren't a major risk, a major source of transmission. Obviously we need to emphasize hand washing, but that's to a smaller degree compared to the main transmission route, which is through the air. Okay, so SARS-CoV-2, as you're all aware, is the virus responsible for causing COVID-19. And again, the CDC suggests that the primary form of transmission is through these large particles. Large particles as droplets, they're defined as 5 to 10 micrometers in diameter or larger. However, there is now emerging evidence that shows aerosol transmission is also likely form of transmission. And these aerosols are much smaller in diameter, less than 5 micrometers in diameter. So what is the difference between droplet versus aerosol transmission? So a person can emit SARS-CoV-2 through either droplets or aerosols when a person coughs, sneezes, just talks, or even exhales. Now, large droplets are too heavy to remain in the air for long periods of time and settle out to the floor rather quickly. However, when a droplet is ejected, from the person, they may convert to aerosol particles, again, with a much smaller diameter, and remain airborne for longer periods of time. These larger particles, you can see down here, quickly reduce in size. So basically they're coming from a very humid environment to a drier environment. So they can reduce in size, and by reducing in size, they stay airborne for longer periods. You can see on the top right here, let's say a person coughs and 100 micrometer particle comes out. Due to the large mass, that wouldn't travel very far, less than 2 meters, and stay airborne for only 5 seconds. However, it's possible that this particle quickly evaporates, so it reduces in size and diameter. By reducing in size and diameter, it can travel almost double the distance and stay airborne about 10 times longer. And then furthermore, if a 10 micrometer particle is ejected and reduces and evaporates down to 1 micrometer, you can see how much farther it would travel and how much longer it would stay airborne. So very little data exists about the size distribution of SARS-CoV-2 particles from infected individuals. This table here is from ASHRAE. ASHRAE has done a magnificent job of providing resources for people as they try to figure out ways to return to work. So I highly recommend checking out ASHRAE. This is the website down here. For resources about ventilation and just guidance about returning to work. So this table is from ASHRAE, and it summarizes a study done about influenza particles. So we really don't know the size distribution for SARS-CoV-2, but we have a lot more data about influenza. Now, if you look just on a pure numbers basis, so a number concentration, you will see that the vast majority of particles emitted from a person infected with influenza is going to be towards the respirable, so less than 4 micrometers in diameter or smaller. However, if you look at the amount of actual viral amount that's emitted, this is going to tend to skew towards larger particles. So, while size of the particle is important, neglecting volume and surface area, these might be actually much better at characterizing the amount of viral concentration there that's emitted compared to size. So for influenza, for the amount of virus, about 80% would be in the 1 to 10 micrometer range, only 20% in the very small, less than 1 micrometer range. And this becomes important when you're trying to figure out controls, air filtration. So we'll come back to this topic a little bit later. Okay, so the bulk of this lecture is really going to be talking about infectious risk assessment and how to apply an infectious risk assessment to your own building, rooms, etc. So infectious risk assessment is useful in predicting the risk of a transmission of infectious agents in different indoor environments. Now, there's a number of models that can be used for infectious risk assessment. The one we're going to talk about here is the Wells-Riley model. Now, all these models are based on the assumption that particles are generated from an infected person, and there's a susceptible host nearby, and that the infection can survive the immune defense of that infected host. Now, this is much easier and it's not as complicated as something like CFD models. Unlike CFD modeling, you can estimate transmission rather quickly with few inputs, but you're not getting the same level of accuracy. Okay, I mean, these are very simplified models with a lot of limitations. But when you're looking at a lot of different spaces and you don't have the resources, like to do a CFD type model, this could be a good way for you to help prioritize your risk, look at the resources that we needed in different spaces. So this is how these models can be applied. Also, determine time for safe occupancy. So how long, let's say we're going to talk about, school. So how long, if you're, have children switching rooms for lessons, how long would you need maybe to allow no occupancy so the next class can switch with little risk, etc. Okay, so the Wells-Riley equation was developed by Riley and colleagues to estimate transmission during a measles outbreak in New York State. Now, the equation is based on the concept of quantum of infection, and this was first proposed by Wells in the 50s. Okay? And therefore you have the term Wells-Riley equation. Now, in the next few slides, we're going to talk about the quantum of infection. But basically, this signifies the smallest dose of any infectious agent that can cause an infection in 63% of the susceptible hosts. So on the right side of the slide here, we can see the Wells-Riley equation. Now, as we go through this lecture, we're going to show the modified version of this, but this is its first iteration and it's most simple, okay? So basically the probability of transmission, which is from a 0 to 1, is going to be a function of the number of infected individuals, this quantum number, which we're going to talk about in the next slide, the inhalation rate, the time that a susceptible person is in the room with an infected person, and then finally, outdoor airflow. So Wells first used the term quantum to indicate the dose of an infectious droplet nuclei necessary to initiate infection in, again, 63% of susceptible hosts. You know, it's important to understand that quanta is not a physical unit, okay? It's a hypothetical infectious dose unit that's going to be back calculated from epi studies. Now, this quanta number may consist of one or more infectious particles. And the quantum number is a function of the type of infectious agent and the activity that is generating the particles. So if you look at the literature right now, there is quantum numbers for SARS-CoV-2. There's one study that's been published that looked at a quantum number from singing. There was an outbreak early on, and they back calculated a quantum number based on that outbreak. There's another quantum number that's just basically for light activity. So just daily, everyday movement, not so much singing. So this quantum number combines the likelihood of respiratory deposition, infectivity, and the amount of infectious particles generated into one single number, okay? And on the right side of the slide here, you can see quantum numbers for selected diseases. So like the quantum number for tuberculosis is between 1 and 50, while measles has a much higher quantum number. It's much more infectious, 570 to 5,600 quanta per hour. Okay, so to understand the assumptions of the Wells-Riley model, as well as its strengths and weaknesses, we need to review, I think something that a lot of industrial hygienists might be much more familiar with. So actually, I took this from a standard ventilation textbook here, except instead of what you might be used to for something like this, an industrial, generation source, you actually have a person in there. So we have our simple box model, and we have, in this case, one single generation source, so an infected person. They're emitting small aerosol particles into the air. And we have exhaust, and that exhaust air is being replaced by clean air. So in the most basic form, the Wells-Riley model only considers a steady state concentration. So we're looking at, right here in our ventilation equations, we've achieved equilibrium between our generation source and our our exhaust. So that is one assumption for the Wells-Riley model. The second is a well-mixed room. So basically, instantaneously, you're going to have a well-mixed room. We know that assumption is not correct, but that is one of the assumptions with the Wells-Riley equation, that you have an instantaneous steady state concentration, or excuse me, an instantaneous well-mixed room. So when we're looking at the limitations, so what we just talked about, the model assumes that you have an infectious agent that's instantaneously and evenly distributed throughout a room. We know that obviously that's not a correct assumption, but that is one of the assumptions for the model. The well-mixed room may be valid for a longer duration, but not as likely for a very short duration in large rooms. So when we talk about the nail salons, we can see we made modifications to this to look at, a concentration that's increasing and then decreasing. This also ignores room geometry and turbulent airflows. And this is also important. It only considers aerosol transmission. So it does not consider droplet transmission, only aerosol transmission. And it also really doesn't take into account any sort of concentration gradient. So even if you have a well-mixed room, there's going to still be a larger concentration by the source. This neglects that. And then finally, that quantum number. I mean, when you're dealing something with like SARS-CoV-2, we don't necessarily have a quantum number, so this, is another limitation. It's derived from epi studies, the quantum number, but its accuracy is still a little bit unknown. But the big strengths with this is it can be done quickly with few inputs. During a pandemic like COVID-19, when you're especially returning to work, this can be done, with very few inputs, as opposed to something like a CFD type modeling. And it really can help you develop, your control strategy of where exactly do you need to target your controls, where do they need to be implemented. Okay, so I just have here on the slide just a summary of inputs, and we'll go into the next, how I applied these. But these are the summary of the inputs that you need for the model. So you can divide this into both your room variables and then people variables. So in terms of the room variables, you need to know the outdoor airflow rates. If you do incorporate filtration, air filtration, we'll talk about that in a little bit, your supply rates, the MERV rating on the filter, your room volume. In terms of the people characteristics, inhalation exhalation rates. A good resource for the inhalation exhalation rates are the EPA risk assessments. They have inhalation exhalation rates for by different ages, gender. So that's an excellent resource for obtaining these variables. Time, it's really going to be up to you as the risk assessor. When we talk about the school, the time was pretty easy because we have a standard school day in New York. Otherwise, that's going to be just really up to you to understand the time activity patterns within that space. And then finally, mask wearing. So I know there's been a number of webinars about reduction using a mask. I'll show you, what we decided in terms of, how we figure what we used as reduction from wearing a mask, but this can also be found in literature. So the first study I'm going to talk about is the New York City school study. Now, this wasn't done directly, or the data wasn't really collected to, we didn't have the study in mind. It was originally collected for an indoor air quality assessment in New York City schools. So between 2017 and 2018, we sampled 101 classrooms in 19 different schools in New York City. Again, this was really done to look at indoor air quality and assess health symptoms among teachers. But later on, we thought, we could use the data that we generated from this to look at risk inside classrooms, because I know that was especially, an area of interest during our reopening, because schools, there is an option in New York City for in-person learning in schools this year. So overall, we sampled 101 classrooms in 19 schools. We broke this out by heating season versus cooling season. So we had 86 classrooms during the heating season and 69 classrooms in the cooling season. And then we sampled 54 classrooms in both seasons. So the objectives of this study was to look at, first, we needed to estimate outdoor airflow rates. So we did not have the actual schematics for the 101 classrooms. So we had to back calculate what outdoor airflow was in the classroom based on CO2 concentrations. The second, we wanted to calculate the risk of SARS-CoV-2 transmission in New York City schools. And the assumptions we used were under steady state conditions. And we want to look at the risk from student to student, student to teacher, and then teacher to student. And then finally, we want to look at different factors that may influence the risk of transmission in these classrooms. So on the slide here, we can see the classroom characteristics for those 101 classrooms and the 19 schools. So on this side, these are the the schools characteristics here. So again, we sampled in 19 schools. The bulk were in Brooklyn and Queens, to a lesser extent, Staten Island and Manhattan. This does roughly look like the population of New York City. This probably doesn't really look like the rest of the US, or at least maybe the Northeast, but not so much the rest of the US. So we actually sampled 5 schools that were greater than 100 years old. Now, how generalizable is that to the rest of New York City? It was a slight oversampling. So if you look at elementary schools in New York City, about 16% are greater than 100 years old. So, we did oversample schools that were greater than 100 years old. But more than half of elementary schools in New York City are greater than 50 years old. So, definitely, schools in our area are incredibly old. Now, if we look on the right side here, these are the classroom characteristics. Overall, this is in metric units, but if you just look by feet, the classrooms are about 20 by 30, so about 600 square feet. The median number of children in the classroom, about 24. So I wouldn't say these classrooms were overcrowded, but it definitely were. We had 24 students. Median number of students was 24. So a fair amount of students per classroom. And then, this is important. Before New York City did reopen the classrooms, they did look at classrooms that had broken windows and attempted to fix it before they reopened. When we first collected this data about 2 years prior, about 18% of classrooms had broken or inoperable windows, but the vast majority did have windows that were able to open. Okay, so as I mentioned, we didn't actually have the schematics for the classroom. So we didn't have the amount of outdoor airflow within the classroom. So what we did was we estimated the amount of outdoor airflow based on the CO2 concentrations. So the way the study was designed is we would leave this carbon dioxide sensor in the classroom for about a week. So when the class was in session, we would, take the CO2 measurements. So only when the children and teacher were in the classroom. So we had the CO2 measurements for that about 6.5 hour day. And so we averaged by day and then averaged by week to get our weekly average CO2 concentration. So we have the weekly average CO2 concentration. We had the approximate background concentration. And this is from ASTM. Basically we average males and females. We use 6 to 11, and this is the CO2 generation. So using this equation here and the difference between outdoor CO2 and indoor CO2, you can get the, in this case, it's cubic meters per hour, or CFM. You can get the airflow rate per person. And then remember, we had the number of people in the classroom. So if you multiply by the number of people, we had the outdoor airflow rate. So this is how we estimated it. Ideally, it'd be better if we actually could measure airflow rate or have the blueprints, but because we can do that, we use CO2 concentrations. So on the slide here is basically the indoor air quality, for the classrooms. So during the heating season, about 900 ppm of CO2. This was about 100 ppm larger than the cooling season. But you could see, I mean, for 24 students per classroom, outdoor airflow was, pretty good in these classrooms. Obviously, in the winter season, we had drier relative humidity compared to the cooling season. These were in line with guidance about indoor air quality in the classroom, temperature, and relative humidity. This is just a breakdown of the outdoor airflow, but there was a significant difference. This is matched by classroom in heating compared to cooling. Also in classrooms that had an HVAC system compared to classrooms that didn't. So classrooms without HVAC system, as expected, less outdoor airflow compared to schools that did. And this was especially seen in the cooling season. Okay, so what we used for this to calculate risk was the modified Wells-Riley equation. So it had some modifications to the previous one I introduced a little bit earlier. So remember, we just solved for Q here. So from the CO2 concentrations, we estimated our outdoor airflow. Now, other variables that we needed to include in this was all students and teachers in New York City are required to wear masks. So there's a reduction for wearing a mask. We used a 30% reduction. Studies have found a much greater reduction, but given that these are children in elementary school, there's no data, and to be conservative, we used a 30% reduction, just because, we didn't want to underestimate risk. The inhalation rates were specific for the age group. So remember, we looked at transmission risk for student to student, student to teacher, and teacher to student. So the inhalation for both student and teacher was changed depending upon what probability we were trying to estimate. The number of infected people was always 1 in the classrooms. And the 2 other additional losses that we put in here was gravitational losses from settling and viral inactivation losses. Now, both this is from the literature. We did not derive these values. These were from published studies. But for gravitational settling losses, basically, it was 0.24 air changes per hour. So by multiplying by volume, we're in the same units as airflow, and we can just simply add these losses to our airflow. And for the amount of time, we just considered 6.3 hours. That's the length of the classroom, or excuse me, the school day. We didn't consider any additional losses from the HVAC system. One, they were only using MERV 8 at the time, and still, I don't know if they changed that to MERV 13. So there'd be very little reduction from the filter. Second, some classrooms didn't have HVAC system. And third, some that did have an HVAC system, basically they had an exhaust, and the replacement air was from a wall unit or just maybe a open window. So that a filter wouldn't do anything. Okay, so you can see the different inputs that we use for estimating risk. Again, the inhalation rates were from EPA risk assessment. The quantum generation, we got this, this was from a published study. This was one of the first studies by Bunanu et al. They had derived the adult quantum number, and from their methods, we derived a children quantum number. And then here you can see the mass reduction. We use 30% reduction. So basically 30% decrease in the quanta generation and 30% decrease for a susceptible person. And then the classroom specific variables, we talked about the outdoor airflow, and the volume was needed of the classroom for these losses. Okay, I don't want to spend too much time on this just for an interest of time, but there have been a bunch of studies during the pandemic that have been published that have reduction from wearing a mask. You can see the citation right here, but basically this author found that there's about a 70% reduction in transmission by wearing a cloth mask. So, we feel using a 30% reduction definitely errs on the side of caution, which I think is important when you're, estimating risk to children, just because we really don't know that they can wear a mask for 6.5 hours. Okay, so overall, we found that the probability of transmission in New York City classrooms was small. The probability, ranged between 0.0015 to 0.81. So basically, you had a probability of 1 out of 700 to 3 out of 4. Overall, the average probability, though, was pretty low. The greatest risk of transmission was from teacher to student compared to student. So you had about a 5 times greater risk of transmission looking teacher to student compared to student. And then we also found mean transmission was much greater in the heating season compared to the cooling season. Obviously that's due to the decreased amount of outdoor airflow in the heating compared to the cooling season. So you could see probability by season over here, about 25% decrease in the cooling compared to the heating season. So on this slide here, you can see the probability by your HVAC system and building age. So the building age, basically you'd half the transmission risk probability in schools that were greater than 100 years old compared to schools that were less than 100 years old. And that's likely due to, just a school that's 100 years old. Obviously, it has a lot more infiltration from outdoor air compared to, the newer schools are obviously constructed much more purposely to maximize your energy efficiency compared to those very, very old schools. And again, as expected, classrooms that had some sort of form of HVAC system, they had greater outdoor airflow, and you could see a smaller risk with schools with some sort of HVAC, whether it was just an exhaust or any sort of HVAC system. So overall, we found generally low risk of transmission in New York City classrooms. I think somewhat surprisingly, the risk was the lowest in the older schools. And that just was due to the amount of outdoor airflow in those older schools. We found risk was much higher, so about 5 times higher for adults than children, and the risk increased during the heating season. Based on what we found, obviously we need to maximize our outdoor airflow, either by opening windows, some sort of natural ventilation that could really reduce the risk. New York City is trying to do that. When we published this in December, they still had not upgraded all their filters, but they were trying for classrooms that did have HVAC systems to change from a low MERV rating because they're using 8 to something higher, like a MERV 13. Finally, there needs to be, greater just training among teachers, because they are at the greatest risk for, wearing face coverings properly. The CDC now recommends double masking, a mask with a nose bridge, but there needs to be, greater training among teachers to how to wear a mask properly. It's I'm hesitant, to teachers to wear N95s. I mean, obviously, I don't know what kind of compliance you would get. Obviously, they'd need to be fit tested. So, I don't know if that would be a realistic option. Obviously, now with the vaccines, teachers are a priority, so they are getting vaccinated. So that should reduce their risk. So we published this in Environmental Research, and here's the citation, just if you want to have any questions, want to go back to it. Now, I just want to briefly just talk about removal from filtration. This was not something that we considered for our paper here. These are from ASHRAE, but you can see ASHRAE had recommended a MERV 13 or higher. This is what New York City classrooms will be installing, or schools will be installing in their classrooms. You can see, we talked about earlier about the size distribution of the particles. So this should capture the vast majority of the viral particles using a MERV 13 or higher. Now, in the event of this, you can add this to the models. So instead of just having the outdoor airflow, you could have that recirculated amount times the filter removal, and that can be added to your outdoor airflow to get, the total amount of supply air with filters. And I won't go into this too in depth, but here's where you could find just this information. I pulled this from just this was an auditorium, but you can see right here, the amount of supply air, the amount of outdoor air. This is on the ventilation diagrams. So basically, if you subtract your outdoor air from your supply air, you get the amount of air that's being recirculated. If you multiply that by the filter collection efficiency, and then add that to the outdoor airflow, you get your total of outdoor airflow. Again, that's how you would do it if you did have filtration in the air. Obviously, for the schools, they didn't have that, so we didn't consider that. Okay, so finally, I will just go into non-steady state risk estimations, and then we should have enough time for any sort of questions. So far, with the classrooms, we only considered steady state concentrations. And this made sense to us. I mean, the way that we were dealing with elementary school children, the way New York State had their reopening plan, the kids did not switch classrooms. So they're in that classroom throughout the day. They're in there for a fairly long amount of time, 6.5 hours. So we felt that a steady state concentration, like right here, would be appropriate. However, what happens when you have, businesses where people come and go? Okay, so I'm going to present how we did this for New York City nail salons, but there was a study looking at post office. This was out in Europe, but post offices, something like a convenience store. You wouldn't want to use this for like a large supermarket, but something like a very small convenience store, where people come in, generate the infectious agent in that space, leave, and then you have a decay. But there still could be a risk both when that person first comes in there and you're on the increasing side, and then they leave and you're on the decreasing side. So you could say this is just simply your ventilation equations. You're going to have to modify that, obviously, for a quantum number, but this is something that you all are probably familiar with, your just basic ventilation equations. So, why do we, care about nail salons? Well, in New York City metropolitan area, this is actually a fairly large business. So in New York City, we have 2,000 nail salons, 800 in Manhattan alone. These are really small businesses. I got into, doing exposure assessments in nail salons. But since we had this data, we thought we would look at the risk transmission when New York City began to reopen their businesses. So, close to 30,000 workers work in New York City nail salons. So this is a fairly large industry within our area. So that's why we did these type of modeling. And additionally, they're small. So, you don't want to apply these Wells-Riley models to huge businesses, large volume, physical volume. But New York City nail salons are small. So I'll show you the average size of one. They're quite small. So actually smaller than a classroom. So on the slide here, I basically have the quanta concentration. So we'll talk more about how we derive this in a little bit, but this is for a worker in the nail salon. So you can see, we're assuming the worker's in there for 8 hours at a time. You can see that the quanta, quickly increases, and with about 45 minutes, 15 minutes, a steady state is achieved. So for the workers, based on this, we just use steady state concentrations to estimate transmission for workers. But for customers here, because a person is really not in a nail salon for that long a time, it's usually less than an hour. What you have is a scenario like this, where you have quanta concentration quickly increasing, the person leaves, and then you have that decreasing. So there are slightly modified equations because we're not dealing with a steady state, we're dealing with a non-steady state. So again, these are things that you probably are familiar with. Instead of a contaminant concentration now increasing, you're figuring out a quanta concentration here. This is for the increasing. And then the decreasing, you'd use this equation here. And again, that is for figuring out the quanta concentration. Now, once you have that quanta concentration, you would take the average of that, and that average, here you can see the average. So like, let's say an infected customer comes in, they stay for 45 minutes and then leave, and the next customer comes in, they still have a risk of becoming infected. So their risk is going to be a function of this average quanta concentration over the duration that they're at the nail salon. So you would take the average quanta here, you'd plug it into this equation here, and then you'd figure out the probability of transmission. Okay, so quickly, so I'll just go through, how we calculated this, and then we can open it up for discussion. So like the school study, this nail salon project really wasn't about looking at risk of transmission. We had previously published a study looking at exposure among workers in nail salons. So we sampled 12 nail salons in New York City. We sampled from Thursday to Saturday. We looked at a number of different chemicals, but we did look at CO2 concentrations as well. So you can see the average CO2 concentration on here. So larger than what we saw in the New York City school study. And you can see this, we sampled the 12 different salons. So it was evenly distributed between Brooklyn and Manhattan. The volume of the salons, they're fairly small. So 8,100 cubic feet. So, not super large. Some, salons were pretty densely packed. So we had one salon that's about 3,000 square feet and had 5 manicure and pedicure stations. So they had a lot of workers, a lot of customers, and then, not a lot of space. Okay, so these are, pretty dense. The big thing, and this is also really important for reopening, it's that a lot of the managers had no clue how their ventilation system worked. So, we did this study because New York State had passed a new ventilation requirements in nail salons. So we wanted to estimate, what the current airflow was and, exposure in there. But we also asked the manager about their ventilation system. And in order to be compliant with New York State law, you needed to have 25 CFM per person of airflow. And you also have to have it ducted outside. It has to be running all day. But when we talked to the managers, a lot did not know if it was recirculated or ducted outside. We had 2 salons that had no ventilation system whatsoever. So that's really important because the way we can control transmission indoors is by ventilation systems. But a lot of our small businesses really don't know how these operate. So that that's a key public health component of this is educating small businesses on their ventilation system and giving them guidance on how to use it. So basically I stratified, we had those 12 salons. Green means that they were compliant with the law. So they had 25 CFM of outdoor airflow per person. Yellow meant they met that the New York State regulations. However, they only achieved that by having the windows and doors open. So they actually weren't in compliant because it wasn't through a ventilation system, but they did have sufficient outdoor air. And then red meant they weren't compliant in the law. One of the findings we saw, and granted there's only 12 out of the many nail salons in New York, but the salons that were compliant were the largest salons. So they had the most customers, most square footage, compared to the ones that weren't compliant, which were much smaller and had a lot less customers in there. Okay, so we looked at 5 different exposure scenarios. The first 3 were for customer to customer transmission. So, I'll let you look through these, but, scenario 1 susceptible and 1 infected person enter a salon and stay for 30 minutes. 2, 1 infected person stays for 45 minutes and then someone leaves or enters 30 minutes after the infected person leaves. Scenario 3, you have a susceptible and infected person come in for basically 2.5 hours. So these are all the customer transmission scenarios. And then this is the worker transmission scenario. So a worker is in there for 480 minutes. And what's the transmission risk to another employee in there? And scenario 5, a worker's in there for 480 minutes. And what's the risk to a customer? And we looked at our assumptions were there was a 70% reduction from mask wearing. And then we looked under steady state for the workers and then non-steady state for the customers. So this slide is there's a lot there. But the big thing, overall risk was pretty low. The biggest risk were in salons that were non-compliant. So in non-compliant salons, there was about 2 to 6 times higher risk of transmission compared to salons that were compliant. And obviously, just by function of they're there for 480 minutes, the greatest risk was employee to employee transmission. So in these non-compliant salons, you basically had, a little bit more than 3 out of 10 risk of transmission compared to a compliant salon, which about 1 out of 10 risk of transmission. So realistically, we really need to target the workers that are, working in these salons, obviously for vaccination, and then also proper mask wearing, double mask wearing, et cetera, because they're at the greatest risk of transmission. So, like I said, overall, we found that in salons with adequate airflow, so basically airflow that met the New York State regulations, our transmission risk was pretty low, especially customer to customer transmission. So less than 1%, so less than 1 out of 100 risk. I think the big thing is that we learned from the study is a lot of managers just simply don't understand the ventilation system. They're not turning it on regularly. So, we can achieve a much lower risk of transmission in these spaces like nail salons, but we need to have, better public health education guidance that the, exhaust needs to be turned on all the time. And when it's warmer outside, utilize natural ventilation, because that's the way we can further reduce risk of transmission in these spaces. And then we published this study recently in the Journal of Toxicology and Industrial Health. So this also has, again, all the methodology that we use in case I went too quickly. So I can open it up to questions now.
Excellent. Thank you so much for your presentation. At this time, if you have questions, you're welcome to enter them into the online Q&A, and we'll do our best to get to as many questions as we can. And also, for anyone who's curious, we do have a direct link to those articles right on the web page in which you all registered. So if you wanted to see a link to those articles, that's also available online. So our first question, based on all of the limitations with the Wells-Riley model, should we assume that the risk is being overestimated or underestimated?
Yeah, that's a really good question. So if you're using the steady state equation, so you're automatically assuming that you have a well-mixed room instantaneously. So for the initial infected person coming in there, you definitely are going to be overestimating risk. You are then underestimating risk because it doesn't really consider proximity. So, we know that there's going to be some sort of gradient that, from an infected person, that you're going to have a higher just amount of infectious particles near that person. So this doesn't consider that. So it both underestimates and overestimates the risk. Now, there are other mathematical models that we looked at. They do require, skills in Python or R, which a lot of industrial hygienists probably won't have. So again, look at this as a way to prioritize your resources. So if you find areas with very, very high probability, there are ways to reduce risk. So, possibly, let's say just easy portable HEPA filters, that could be used. Making sure that windows are just open. Making sure that the MERV rating is changed on the filters. So that's, one way you should maybe look at using these equations. Not so much that you're going to have the most accurate probability, but you're going to have a way that you can prioritize your controls.
Thank you so much. And what is the difference between well-mixed and steady state? For example, does steady state equal no exhaust?
So steady state would mean that you're in equilibrium with the generation and exhaust. So that is steady state. Well-mixed room basically means that the infectious particles are evenly distributed throughout the room, regardless of time.
Thank you. We also have a question on infectious particles. Can you also talk a little bit more about the difference between infectious particles and quanta? What is the difference?
So basically a quanta number, and that's earlier in my presentation, a quanta number is a hypothetical unit. It's not a real unit. Basically, it incorporates a number of different characteristics of let's say like SARS-CoV-2. So it incorporates size distribution, it incorporates infectivity of that agent. It incorporates, deposition in the lungs. So, like I said, it's a hypothetical unit. It's back calculated from epi studies.
Thank you. Someone else says, great presentation, thank you. They're wondering if you can talk a bit more about the environmental conditions that showed a 0.81 transmission probability.
I believe that was one classroom that averaged CO2 levels for it was about 2,000 ppm of CO2. So basically they did not have a lot of any natural ventilation in there. Granted, we did this 2.5 years ago, so I don't know the exact characteristics of the classroom, but it obviously did not have adequate ventilation. So I think that was the main defining characteristic of that space. It just did not have adequate ventilation in there. But I don't know the exact details of whether or not it had windows, they didn't open them, etc.
Thank you. Also kind of building on this, another question, schools with HVAC had lower transmission rates, but older schools, which are less likely to have HVAC, also had lower transmission rates. How to determine which is more important, HVAC or more outdoor air incursion through less airtight buildings? Is there kind of a way to determine which is more important, or do we know?
Well, in multivariate modeling, we found that older classrooms were more significant, but I mean, obviously you can't change a school's age. I think realistically, you need to use a combination of controls. I mean, the reason older schools had lower transmission, obviously infiltration, also they were using the windows to provide ventilation. So, ideally maybe a combination, natural ventilation in there, use your exhaust ventilation in the classroom, always keep that on. Same thing with the nail salons. I mean, they have exhaust ventilation. If they just kept that on all day, opening up windows, you would obviously have the greatest amount of outdoor airflow and a reduction in transmission.
Thank you. And for the school studies, did you look at teacher-to-teacher transmission? Also, did you assume any vaccination status within the school study?
So we didn't assume any sort of vaccination. The reason because when we first published this, the vaccines didn't exist. So when we were going through the transmission estimates, the vaccines weren't even, they haven't been approved or anything. So we didn't assume vaccines. We also didn't assume transmission between teacher to teacher. In our classrooms, I think there's only 1 or 2 classrooms that had 2 teachers in there. So I know obviously teachers, talk in a workplace setting, but we did not consider that.
Thank you. Another question on quanta values. You presented a range of quanta values, but what was the quanta value you chose for the model of SARS-CoV-2?
I had that back in the slides. It was 29 quanta per hour for children, and then 142 quanta per hour for teachers. And we also use that 142 for the nail salon workers. And that was based on a previously published paper. So we only modified for children, but we used a previously published paper to to drive that value. And that was from Bonanno et al. And if you look at the papers that that are available that we published, the quanta number where we got that from is in there. So it has the citation in there.
Thank you. Another question, in order to evaluate the actual particulate removal in a space due to outdoor air, HVAC filtration, and portable air filters, a colleague recently suggested releasing particles and measuring concentration decay using a direct reading instrument. Have you encountered this technique in assessing ventilation?
I'm sorry, can you just repeat that one more time? I'm sorry.
Sure, no problem. So in order to evaluate particulate removal in a space due to outdoor air, HVAC filtration and portable air filters, a colleague suggested releasing particles and measuring the concentration decay using direct reading instrumentation. Have you encountered this technique in any of your efforts to assess ventilation?
No, I'm sorry, I haven't.
Excellent, thank you. Just scrolling through, we have lots of questions, so thank you all so much for your engagement. We have time for just a couple more here, so we'll do our best. Given the results found in the NYC school study, as well as the nail salon study, finding transmission being low, especially with HVAC units and operable filtration present, would you say that the use of air ionization devices would not be necessary? Would it just be better to implement better filtration systems than even considering air purifier systems?
Yeah, that's outside of my area of expertise. We did not include any sort of air filtration in there. I would look at ASHRAE. ASHRAE has different controls that they recommend. One of them is air filtration. So I would defer you to ASHRAE. They have a great resource for looking at controls of COVID transmission.
Thank you. And related to the NYC school study, why do you think that transmission is higher between teacher-student than student-to-student? Do you have any ideas?
Well, yeah, I mean that is purely a function of the model. So, am I still sharing my screen?
Yes, you are.
Okay. So if you look at this, so one, the quanta generation for adults is much larger than children. And secondly, inhalation rates are almost 4 times higher, 3 times higher for children than adults. So that goes into your probability estimates. So obviously probability is a function of the amount of the inhalation rate. So we know adults are greater than children. And then also adults have a higher quanta generation rate compared to children.
Thank you so much. And I'll take on our last question here for the day. How do you see this model applying to larger warehouse type work areas? For example, a high bay workshop with a ceiling of around 20 plus feet and several thousands of square feet. Do you see a way to apply that?
No. I would look at the literature, but these are usually only applied in very, very small settings. With something so large like that, I mean, there is other models, but again, you have to have like skills in Python or R. They become a lot more complicated. So I wouldn't use something like that for a very large space. With the classrooms and the nail salons, they're pretty small.
Well, thank you so much for your time today. And thank you to everyone who joined us for today's webinar, for your attention and engagement and all of our excellent questions. The Education and Research Center Industrial Hygiene webinar series will take place the second Tuesday of each month. And this series is also in addition to our ERC Ergonomics webinar series, which is the third Wednesday of each month. Our next IH webinar is going to be on Tuesday, May 11th, in partnership with the University of Cincinnati, ERC, and Sergey Grinspan, PhD, and we'll be looking at respiratory protection in the COVID-19 pandemic, research findings from the Center for Health-Related Aerosol Studies. Please be sure to check out our website for more information and other upcoming events at coeh@berkeley.edu/aboutce. Thank you all so much for being here today, and a special thank you to Dr. Pavilonis.
Thank you very much.
Have a great rest of your day.